At the first relapse or progression, most of us would use both CT scan and functional imaging like PET scanning. Again, for the same reason we talked about in the frontline setting, to make sure that there is no evidence of transformation. And that's usually, you can tell from the activity of the PET scan in certain areas. And if there's certain lesions that have a very high SUV, then you will have to do a biopsy there to rule out transformation. Because again, this could guide therapy. If there's transformation at the time of relapse, then a salvage therapy plus transplant may come to mind. If there's no transformation, then the options, if you started with R-CHOP, most of us would give R-bendamustine. If you started with R-bendamustine, most of us would switch to R-CHOP.
It's really important to look at the duration of response to upfront therapy when deciding what to use for subsequent treatments. For example, as I mentioned earlier, patients who have an event within 1 or 2 years of completion of therapy have really a poor outcome, and there are no regimens that are specifically designed for these patients. There are clinical trials that are focusing on them. They need a different approach. For the other patients whose relapse occurs years after that, there remains the possibility of reusing the same treatment, although in this day and age where we are having more and more novel therapies coming down the pike, it's unlikely you would do that. But what you recognize is that patient population tends to respond and to respond and to respond. Eventually they become resistant to therapy, but that's years out. It's the other group that progresses in 1 or 2 years that we really need to be concerned about, and hopefully even identify who they are before treatment. Now, there is destined to be, hopefully in the near future, a national study focusing on that group of patients. It's going to be for patients who received a bendamustine-based induction regimen, and for those patients who relapse within 2 years, they're going to be randomized to one of 3 approaches. A standard arm, most likely obinutuzumab CHOP or O-CHOP, obinutuzumab lenalidomide, or obinutuzumab idelalisib. This may change as the study comes closer to activation, but this is the concept. Test standard versus investigational approaches, particularly non-cytotoxic regimens.
The average lifespan, median survival of patients with follicular lymphoma is now measured in approximately 18 to 20 years. That means that those patients will require multiple treatments in their lifespan. The 3 widely used regimens that are commercially available, FDA approved, are the R-CHOP, R-Benda. And when you fail both, the only drug that is currently approved is idelalisib, the PI3 kinase delta inhibitor. But outside these treatments, and knowing that patient will still need treatments, you can't just say, well, these are the only approved agents, I can't give you any more treatment. Many of us depend on guidelines like NCCN guidelines, where they incorporated active regimens that are not approved officially by the FDA for this indication, but they have shown good activity and reasonable safety profile. So lenalidomide plus rituximab is widely used, which people refer to as R-squared, in this setting, either before or after idelalisib. And there are then other, I think, agents, mainly in the context of clinical trials, that most of us would use.
The role of transplant in follicular lymphoma is, to say the least, controversial. Most feel that there is a limited role for autologous stem cell transplants. There are some studies showing prolonged progression-free survival and maybe prolonged overall survival, but those were highly select patients who had virtually no disease at the time of the transplant. Now, allogeneic transplants may have a role in patients, particularly younger patients, who have few comorbidities, but who have relapsed soon after induction or who are refractory to induction therapy. The use of allotransplants, or at least the displacement of them further down the road, has been engendered by the increasing number of novel targeted therapies. Allotransplants have a substantial morbidity and mortality rate. Other targeted drugs, that's very limited. So it's being pushed and pushed and pushed further down the pike. And in fact, with some new and exciting data looking at CAR T-cell therapy in highly refractory follicular lymphoma, the role even of allogeneic transplants may become subject of historical value only.